So, Allie, we've talked about a lot of routine tests. Tell me about some of the other tests that are a little bit more esoteric, but are necessary if, in fact, you have not been able to make a diagnosis.
So these are some of the tests that you would not be using on every patient that walks into the office with a chief complaint, but they are helpful when they are indicated. And, so far we've gone through a number of interview questions, listened to the patient well, done some examination, looked at the radiograph. But every now and then you may have a patient that doesn't quite fit the mold into any of the tests that we've done so far. And they could benefit from some additional tests that you can use in order to maybe differentiate pulpal, apical, as well as non-odontogenic problems in such given patients. And those are basically transillumination type of tests where you shine a light through the tooth, look for cracks. Taking a CBCT is very, very helpful for many patients that can't be diagnosed with the conventional methods. A cavity test, which is a fairly esoteric, going back to the word test, but we'll talk about that because they might be indicated in some rare cases.
Yeah, I have.
And then the anesthesia tests are basically a form of elimination test. And they're also very helpful. When somebody comes into you, they have pain at the time that they're seeing you, and then you can basically, rule out what areas are not the source and so on and so forth. And last but not least, actually physical surgical exploratory procedures to reflect and look at a closer way directly in area are very helpful too. But let's take a look first at transillumination.
Sure.
And how do you do the transillumination, Dennis? What is your method?
The most important factor is that I use it often when I'm suspect of a crack.
Mm-hmm.
And if you transilluminate directly up against a tooth that has a crack, at the point at which the crack is, you will stop seeing the light transfer through, and you'll get a distinct pattern where you see a lot of intense light and then no light at all. And it's a very reliable mechanism when there is a separation in the dentin of like a crack, that you can be able to see it. And sometimes you are at that point really at a point that you have no other way of knowing if there's a crack, because it's either enlarged visually enough that you can see it with the microscope or with some form of magnification, or you're resorting to this as the way of being able to identify it.
Right. I mean, basically, it's the same thing as in a crystal. You have, the enamel is in a crystal form. You have enamel rods. When you have a crack or a craze line, more importantly, a crack, craze lines don't quite go as deep. But if you have a deep crack that actually goes right through the enamel and the dentin, it acts as a break in the plane that breaks the passage of light. So you end up having a lit part and a dark part. And it could be very helpful in terms of diagnosing cracks, or, in the past we used to call those crack tooth syndrome kind of a deal, and which we could, you could take a look at and use illumination. You have to turn off the lights in the operatory pretty much, so that you can see the tooth.
Yes.
And then you just basically take one of your a fiber optic light or something like that, and you shine it from the side of the tooth, and you're able to see this plane.
Right.
Let's talk about CBCTs. CBCTs are, as we mentioned earlier, have really revolutionized endodontics. Obviously, they've been, really helpful to implant dentistry and restorative dentistry on the implant side. But in endodontics, just in the recent times, after the development of the focal and the limited field CBCTs that allow a fairly high resolution image of a tooth to be reconstructed, through software, and that you are able to come back in sitting at the behind a computer and take these scans and look at these various sagittal, coronal, as well as the axial views of the tooth. Which, by the way, I like the axial view because it gives you a ton of information. You can you can find a lot of the things that you were missing in the past. For example, when a patient comes to you and you have a lesion such as this one you can see on the lower second molar, this patient was in severe pain, and the chief complaint was tremendous chewing and touching pain. There was some swelling on the side of the tooth, and the other teeth were testing vial as a previous root canal therapy in this case, and there is a lesion. So while a radiograph is just showing us a lesion that is present in this tooth, we're really not able to see whether this lesion, or where it lies in a buccolingual direction. And almost somewhat diagnostically, but also from a treatment planning point of view, CBCTs become extremely helpful, because for a given tooth that I was planning on doing an apicoectomy on this tooth, which this patient was referred to do, we took a CBCT, and when we looked at this in a coronal aspect, you can now see that the lesion is actually draining towards the lingual aspect of the tooth. And the lesion and the root itself is very lingually oriented. Now, this patient also had some signs of submandibular swelling, which is really a byproduct. Now you can understand because it was because of the lingual orientation of the tooth. And in lower second molar, lingual orientation of the tooth will cause the drainage of the infection below the mylohyoid attachment, and that results into a submandibular swelling. So a case like this, we decided that instead of doing apicoectomy, a more predictable procedure for the patient would be to do an intentional replantation, and which means that we basically removed the tooth, did the apicoectomy outside the mouth, and put the tooth back in within a 5 to 10 minute time period. So it was really very little extraoral time. And this patient healed very well after 6 months. You ended up getting also very excellent healing there, and the bone is filled in. So this is a case in which the CBCT helped us not only just diagnostically to explain some of the phenomena we were seeing, such as submandibular swelling and so on, and the direction of the lesion, it also helped us with the treatment planning.
I have a question about that, and I have another question for you. With an intentional replant, and all of us as endodontists have done these, I've seen terrific results for many, many, many of them.
Yeah.
What's been your experience? Have you
Absolutely.
seen
Intentional implantations work if they're done correctly on the right tooth, and that's the tooth in which there's no periodontal involvement, a tooth in which there is only a focal problem at the end of the root, the tooth there is no coronal leakage, there's a good restoration, everything is in place, and the root is conical. Because the key with success in intentional replantations is a tooth that could be atraumatically removed without much damage to the surface of the root, and then the rest of that is having a very short extraoral time, do the apicoectomy procedure outside the mouth, and then put it back in. And oftentimes it doesn't even require stabilization. The tooth will stay in place, forms a little clot, and it heals very well. I've had tremendous success with them too.
Yeah, it's interesting, yeah. So let's look at anesthesia for a moment. You listed anesthesia as a test, and that's not usually how anesthesia is used. What do you mean by that?
That's true, isn't it? Because anesthesia is used after you've already done all your tests and you're ready to get started, right?
Yeah. So what is that?
But selective anesthesia could be a test. When a patient comes to you and it has pain that is non-described, is basically to tell you, well, it hurts sometimes in the lower, sometimes in the top. Usually these patients also have a number of restorations, so it makes the whole pulp vitality testing that you've done a little bit less effective or less predictable, if you will. Then what you can sometimes do as a last resort, and especially if they're in pain at the time you're seeing them, would be to selectively anesthetize an arch. So I usually, let's say if they're complaining of pain that they can't diagnose where it is, I may give them a mandibular block, or I may give them a posterior supraalveolar nerve block, and then take out one of the arches as the potential source. And then depending on how the pain reacts, if the pain goes away or not, then at least I've managed to zero in and localize the pain to an arch. A lot of times these pains are so all over the place, the patients can't tell. And I've had patients, in fact, that I have done this. Let's say I've numbed up the maxilla completely. The pain didn't go away. So, okay, so it should be the mandible. So numb up the mandible, the pain still didn't go away. Turned out that it was a TMJ problem. So this is where it comes out to be helpful, because you are anesthetizing the pulps, and then you're taking the odontogenic component of the problem out of the picture. And in that situation, then they could be, not suddenly it reveals a whole other thing. They could be having migraine headaches that is getting transferred to their tooth, and suddenly now you have that information. TMJ problem could be getting referred to the tooth. So selective anesthesia is helpful. Some people have talked about using it with PDLs individually on teeth and moving it down. I've just find that may work in some specific situations, but overall it may not be very helpful because when you give a PDL injection, you can't ever localize it to only one tooth. It's very difficult to know. That could be, intersulcular injection, which is what a PDL injection is actually really an interosseous injection. You're injecting into the bone marrow. So you can have adjacent teeth that get numb a little bit as well. So it's not very reliable. Another test that selective anesthesia helps with, if a patient who comes into you and is having sensitivity to heat or cold and you can't isolate it. Again, a lot of times these are cases where there's massive restorations. Your own pulse vitality tests are not predictable. I mean, numb up a patient on one jaw and then give them a glass of cold water to drink and then see what happens. Again, the goal of diagnosis is to see if you can duplicate the chief complaint. And sometimes duplicating the chief complaint is helpful, and sometimes not being able to duplicate the chief complaint
is helpful.
Is just as helpful. It may not hone you in down to one tooth,
Right.
but it'll hone you down to one jaw, and then you can go
Right,
from there,
right,
putting
right.
together additional information that may be helpful.
You mentioned exploratory surgery. When might you resort to that? I mean, that's kind of, out
It's
there.
a little bit too much, right? Well, we
Yeah.
talked about anesthesia, so let's talk about surgery next,
Okay.
right? So, well, I can tell you that the exploratory surgery is specifically very helpful when it comes to trying to differentiate a tooth that has had a previous root canal and has a deep area of probing and where you don't know if the situation is a crack or a fracture or if it's just a sulcular sinus tract, because you can have a sinus tract as opposed to drain through the gingiva. It could drain through the sulcus, and it will give you deep probing areas.
I would suspect that this is not used as much because of the CBCT.
Yes, CBCTs, that's a very good point that you
Yeah.
brought up, because what can CBCT tell us about cracks or fractures in the teeth?
A lot.
They sure can tell you more than your regular x-rays, than your regular periapicals. Unfortunately, CBCTs, so the research shows that they can give you about 10 or 20% more sensitivity in terms of identifying vertical cracks or fractures, that they can't give you 100% either. So, whereas your periapical x-ray, you have to catch that crack or fracture exactly within 5 degrees. Studies have shown that you have to be within 5 degrees of the plane of the fracture before you can actually capture it radiographically. A CBCT will allow you to, increase those odds that are already pretty low, let's say about 20-30% chance that you can see a fracture on the x-ray. That could boost that up to 40-50% of the time. But still, a good 50% of the time, you can't even see a crack on the CBCT. So in those cases, then you have to make a decision whether you're going to do an exploratory surgery. And the exploratory doesn't have to be oftentimes very deep. Sometimes just doing a gingival flap and pushing the tooth back, you can see
Pushing
a
the
crack.
tissue-
pushing the tissue, the
back.
gingiva back, you can see the root surface enough that you can make that diagnosis.
And all root fractures don't necessarily appear in the crown of the tooth.
No, they don't. They are, you have, when it comes to cracks, you have basically 3 types. You have crazed lines that are in the enamel and so on. Then you have cracks, and the cracks are, they're varied. There's just all kinds. They run the whole spectrum. They could be up coronal on the tooth, in which case, you may just need to have a restoration. The problem with cracks is when they start to pass the crestal bone or go below the CEJ, where they end up acting as a path or a conduit for bacterial from saliva to jump onto them and then go below the gum line. And oftentimes these represent on radiographs in the form of a J-shaped radiolucency or a halo radiolucency around the root. The x-ray of this tooth that you can see here, you have a radiolucency around the root endodontically treated tooth, and the radiolucency is following a J-shaped appearance. And these cases are oftentimes associated with vertical root fractures. And here you can take another angle, and you can see that it's pretty much there. And, cases like this, you may or may not decide to do an exploratory surgery. A lot of this decision-making is not a part of this course, which is about diagnosis, but would be a part of treatment planning. But it's all about allocation of risk to what the patient wants and what the patient doesn't want.
Ali, can I make one mention about that case? That happens to be a fractured root. and the asymmetry of that lesion gives you a hint of it.
Yeah.
But also, when you start to look at the etiology of that fractured root, did you happen to notice the amount of dentin that had been removed during the endodontic procedure?
Yes. Yes.
And this is something that we really are focusing on now, is doing minimally invasive preparations that don't remove unnecessary dentin.
Absolutely. That is the wave of
The
future
future for
endodontic
sure,
therapy.
and what we've been talking about for
Yeah.
a decade now is
Yeah.
now starting to be founded, in reality.
Yeah.
We'll be talking a lot more about that in
Yeah,
the future with
in the
other
future.
courses that we're going to
Yeah.
be involved in. So
Absolutely. But the essence here is that over the past many years, we've removed too much tooth structure, weakened the tooth internally. That's why we've seen a lot of cracks and fractures in a lot of these endodontically treated teeth.
Yeah.
And the hope is that by changing our techniques, that we can hopefully improve and reduce the rate of these fractures. And this tooth, as you can see here, after exploratory surgery and pushing the tooth back and staining the root
pushing
using
the soft tissue back.
I keep after pushing the soft tissue back, you can see that following staining of the root, you can clearly see a vertical fracture both on the buccal and the lingual aspects of not the on the mesial and the distal aspects of the mesial and distal roots. And one of the other tests that is pretty eclectic we were talking about is the
Yeah.
cavity test.
Yeah.
So you've done a cavity test. Let me know.
I have. I've resorted to a cavity test, particularly when I've committed a tooth to pretty much the sense that, this is a tooth that we're going to be treating, but without still having a definitive feeling in my mind. And many teeth that are very, very calcified, particularly in older patients, this is a great opportunity to just simply, without any anesthesia, to go in and see if you can literally just drop in to the pulp
Yeah.
with no reaction whatsoever from the patient. And that pretty well commits not only the tooth to the treatment, obviously, but also, identifies this as a non-vital tooth.
Right.
So it's not something I do generally. I might, on a 2-year period, I might do 2 of them.
Yeah.
You know what I mean? It's just, it comes up. But there are periods of time when your patients have said, look, I'm still having a lot of pain. I don't want it anymore. And I'm committed to saying to them, they're committed to doing the procedure. I'm committed to trying at that point to say to them, if you're willing to do this, to allow me to try a test cavity, let's see whether this tooth actually might be the offending tooth.
I don't know how many patients would actually allow me to do that. I have not done many cavity tests.
You have to be a smooth talker.
I haven't been able to convince anyone so far. But a cavity test is very
out there.
unique in those specific situations where you would be needed, where you absolutely have to do the treatment. You can't postpone it. You got to do it, and you don't know whether you have a necrotic tooth that would be helpful to do.
Could I give 2 things that could come up with that might be the case?
Yeah.
If you have a patient who's been having discomfort or pain for a while, they're leaving for 2 weeks in China. They're going. Okay, they're committed. They
Yeah.
don't want to go, and they don't want to be in pain, and you've come to a point where they realize that, we're going to do some things that are a little bit different here. But you also can sometimes, interestingly enough, you might have a situation where somebody has to go in to have a procedure in a hospital,
Yeah.
and you have to define the patient can't be in pain for 2 weeks once they're in a hospital. They're going to have a hip or whatever it is that they might have. You got to solve the problem. You got to take
Yeah.
your best shot at solving this problem. You can have that discussion about a test cavity, and I've resorted to them, and I've made some very good decisions based on that.
Is that right?
Yes.
That's terrific. Well,
Yes.
there you have it,
Yeah.
folks. Test cavity does have a place in specific and unique situations, and you're going to need to apply it very selectively and surgically, but you can get the benefit of it, especially if your patient's lying out of town. So having said that, it seems like we've already completed the 7 steps, which kind of leads to the culmination of all these 7 steps, which would be the diagnostic stage of finally having the diagnosis. Hopefully at this point, we've done all the tests. We've even done all the other tests. We've even drilled in the tooth
Right.
without anesthesia.
Right.
And now we're going to go ahead and talk about the diagnosis next.